Pancreatitis is an inflammatory condition of the pancreas. Despite the great advances we've made in medicine over the past 20 years, the mortality rate still remains around 10%. There are two classifications of pancreatitis. One is acute interstitial pancreatitis, where the gland architecture is preserved but edematous, and acute hemorrhagic disease, which is characterized by marked necrosis, hemorrhage of the tissue, and fat necrosis. As far as etiology, the most common cause of acute pancreatitis in the U.S. and Western countries is gallbladder stones. Heavy alcohol consumption is a second leading cause, and other common causes include medication, hyperlipidemia, hypercalcemia, and less common causes include scorpion stings, poisoning with organophosphorus insecticides, Ascaris worms in the pancreatic duct, viruses, and trauma. 80% of cases of acute pancreatitis in the U.S. are related to alcohol use or biliary stones. Risk factors are hereditary, cystic fibrosis patients, alcohol use, digestive issues, hyperlipidemia, cholecystitis, surgery involving or near the pancreas, viral hepatitis, mumps, peptic ulcer disease, periarteritis, anorexia nervosa, shock with ischemia, trauma to the pancreas, medications, middle age, HIV, and AIDS. There are 3 risk scoring systems to determine how likely someone may be to get pancreatitis, and those are the bedside index of severity in acute pancreatitis, the Ransom criteria, and the Apache 2 score. The Pathophysiology of Ap is gallstones pass through the common bile duct to enter the small intestine. At the entry of the small intestine, the main pancreatic duct joins or lies immediately next to the common bile duct. It's believed that stones that get stuck in the common bile duct impinge on the main pancreatic duct, causing an obstruction of the normal flow of pancreatic fluid and leading to pancreatic injury. Another way that a stone can cause pancreatitis is by causing a backflow of bile into the pancreatic duct, resulting in pancreatic injury. The exact mechanism of how gallstones cause pancreatitis is not entirely certain, but the association between the two is very clear. There are many clinical manifestations or signs and symptoms of acute pancreatitis. It usually begins with a gradual or sudden pain in the upper abdomen that sometimes extends to the back. It can be mild and become worse after eating. The pain is often severe, constant, and commonly lasts for 7 days in the absence of treatment. A person with acute pancreatitis looks very ill and needs immediate medical attention. Coughing and vigorous movement and deep breathing may worsen the pain. They often sit in the tripod position, which is sitting upright and leaning forward, to provide relief. Most cases require hospitalization for 3 to 5 days, which includes close monitoring, pain control, and IV fluid replacement. Other symptoms can include swollen and tender abdominal pain, nausea and vomiting, which is in 85% of the cases, fever, rapid pulse, symptoms of respiratory failure, confusion, coma, tachycardia, hypertension, mild jaundice, and pleural effusion. As far as diagnostics and testing, it's confirmed by medical history, physical exam, arterial blood gas, and doing a blood test to check the amylase and lipase of the patient for digestive enzymes of the pancreas. They also do a UA, and whenever they get the readings from the blood of the lipase or the amylase, the levels are typically 3 times the appropriate level. In some cases, when blood tests are not elevated, but the diagnosis is still in question because they're presenting symptoms, they may do abdominal imaging, such as a CT. They also may do a trans-abdominal ultrasound, an endoscopic ultrasound, which is invasive, an MRCP, and then the CT is actually usually not performed unless they continue to have these symptoms without blood test results. A pancreatic pseudocyte is one of the complications. That's where a collection of fluid containing pancreatic enzymes forms in and around the pancreas, and it can go away spontaneously, and sometimes it can create an infection. Necrotizing pancreas is something that happens if you get severe acute pancreatitis. In this complication, part of the pancreas may die and body fluid may escape into the abdominal cavity, which decreases blood volume and results in a large drop in blood pressure, possibly causing shock and organ failure. In this complication, if it's not treated rapidly, the mortality rate can be as high as 15%. Infection of an inflamed pancreas is another complication. typically seen in people that have the necrotizing pancreas. If the doctor suspects it, they typically put them on prophylactic antibiotics and a peritoneal lavage. There are pulmonary complications that can happen, such as fluid accumulation within the pleural space and respiratory distress syndrome. You can get pancreatic pleural fistulas, and effusions may result from acute inflammation of the pancreas. You can have renal dysfunction accompanied by acute pancreatitis by direct extension of inflammation of the kidney. Erosion of vascular structures by abscesses or pseudocysts may cause GI hemorrhage. And then extension of pancreatic inflammation may also lead to colonic strictures, fistulas, and perforation. The inflammatory process can lead to splenic vein thrombosis or pseudocyte formation in the spleen. Other severe complications include sepsis, multi-system organ failure, chronic pancreatitis, pancreatic cancer, and death. So there are some non-invasive and invasive treatment methods. To start with, non-invasive, it usually involves short-term hospitalization where you're given IV fluid to prevent dehydration. Analgesics are given for pain relief, and you have to fast the patient for 24 to 48 hours until there's no signs of nausea and vomiting. Once they are over the nausea and vomiting, you start them on a low-fat, high-calorie soft diet. And the next thing is to treat the underlying causes. So you try to figure out why they acquired pancreatitis, whether it's alcohol, so cessation of alcohol use, hyperlipidemia, or other factors they could change in their daily lifestyle. Medications sometimes have been used to inhibit pancreatic secretion, including somatostatin and glucagon. There is a theory that is in debate that is antioxidant therapies. It can be acute pancreatitis can be associated with oxidative stress. So based on these, there have been some clinical trials out there to try to manage chronic and acute pancreatitis, and it is the combination of vitamin C, vitamin E, selenium, and methionine. Alternative therapies are also recommended, not proven to help, but can, in conjunction with traditional medicine, are thought to aid in prevention. Those things are yoga, massage therapy, therapeutic touch, exercise, meditation, laughter, acupuncture, and then going into invasive procedures. You can do an ERCP, and with the ERCP, doctors are able to do a sphincterectomy, gallstone removal, a stent placement, balloon dilation, and if none of those are needed, they sometimes also just do a cholecystectomy and remove the gallbladder. As far as nursing interventions, you want to keep the patient NPO for 24 to 48 hours, like I stated earlier. Once the nausea and vomiting subsides, you want to encourage eating to promote healing. You're also going to want to NG tube suction. You're going to NG tube suction them to reduce the nausea and vomiting while they are still in this state, and it also to remove the hydrochloric acid so it does not stimulate the pancreas. Correction of fluid loss. Once again, I've already stated that. And then medication administration as ordered by the doctor. You're going to want to monitor their vital signs every hour for any changes. Monitor for signs of complications such as respiratory distress, pleural friction rubs, internal bleeding. Check their blood values for amylase, lipase, and white blood cell count for infection. Place the client in a semi-Fowler's position to decrease pressure on the diaphragm. Teach the client coughing and deep breathing techniques, and have insulin ready in the event of hyperglycemia. For the N1 competency, I picked a nursing judgment, and to uphold the nursing judgment competency, it's critical to abide by the standards of practice of care, such as a head-to-toe assessment at the beginning of every shift, monitoring their vital signs every hour until they're in a place where you can keep it at every 4 hours, believing the patient's reported pain level as pain is subjective to each individual, and recognizing signs and symptoms of the disease in case they are worsening and may need to be addressed by a doctor. Providing quality care and proper patient education is also crucial. Discharge planning should start after admission of the patient. It's important to educate the patient on post-hospitalization care and means in which they can minimize another exacerbation of the present disease. The more educated our population is, the better we can manage diseases. By treating each patient with respect and dignity during their hospital stay will remain a top priority. Providing adequate care related to their cultural beliefs and personal preferences will form a foundation for a trusting nurse-patient relationship. For this presentation, my references were obtained from the Pancreas Foundation, Merck Pharmaceuticals, Johns Hopkins Medicine, and Nursing Path.